show the banner. First slide can come up. I'm going to start. Can you bring the first slide on? Good evening, everybody. On the slideshow? Yeah. Good evening, everybody. On behalf of the Executive Committee of the Indian Academy of Cytologists, I, Dr. Radhika Srinivasan, extend to each and every one of you a very warm welcome. We are all in a state of euphoria right now, India having clinched the Neeraj Chopra, having clinched the gold in the javelin throw. And yes, it's a very, very happy day for us today indeed. So this is the 6th lecture in the Jewel 50 series. And the Jewel 50 acronym stands for the Golden Jubilee eWeb Lecture Series. Today we have with us a jewel from the United States of America, a very eminent cytopathologist, Dr. Zubair Baloch from Pennsylvania, who has extensive work in cytopathology and who is an expert in thyroid cytopathology. Thank you, sir, for having accepted our invitation and for giving us your valuable time to share your experience in this topic. The topic you have chosen indeed is so relevant because thyroid FNA is something that is so common in our day-to-day practice. And we are really excited to hear you on this topic. And of course, you're going to take us through all the opinions, the discussions, and of course, the controversies in thyroid cytopathology. And to introduce formally the speaker for today's evening is Dr. Meherbano Kamal, Executive Committee member. She is the nominee for the Indian nominee for the Acta Cytologica Journal. And she is professor at the Government Medical College, Nagpur, and a very eminent cytopathologist herself. And to moderate the session, the Q&A session, which will follow the talk, we will have Dr. Venkat Iyer, who is professor and head at the All India Institute of Medical Sciences, New Delhi. So without wasting much time, it's over to you, Dr. Kamal, to formally introduce the speaker for this evening. Over to you.
Thank you, Dr. Radhika. A very good evening, everybody. It's a great honor to introduce Dr. Zubair Baloch, a world-renowned cytopathologist who basically belongs to Jamshoro, Sindh, Pakistan. Dr. Zubair did his MBBS from the Liaquat Medical College way back in 1985. He did his MS and PhD from Heinemann University, Philadelphia in 1988 and 91 respectively. He accomplished his certification of American Board of Pathology, Anatomic and Clinical Pathology, and also acquired the subspecialty certification in cytopathology in 1997 from the American Board of Pathology. He has been a fellow in oncologic surgical pathology at the Memorial Sloan Kettering Cancer Center, New York, and he has also done his fellowship in cytopathology from Hospital of the University of Pennsylvania, Philadelphia, during the 1996 and 97. He was a bright student right from his undergraduate days and received his first award of Best Graduate of Liaquat Medical College, Pakistan. A series of awards and accolades followed since then, and to name a few, Who's Who among graduate students, Kevin Salhani and Peter C. Novel Teaching Award of Department of Pathology and Laboratory Medicine, University of Pennsylvania Medical Center. He has been an inspirational guru, educator, mentor, and a selfless individual for his patients and students, and is known to go above and beyond to support others. His devotion and dedication made him a trailblazer in his field and fetched him prestigious recognitions from various professional organizations. To name a few, President's Award of Service from the American Society of Clinical Pathology, Educator of the Year Award by Papineau Society of Cytopathology, H.P. Smith Award for Distinguished Pathology Educator from the American Society of Clinical Pathology, and the most recent feather in his cap is this year is the Simon Flexner Award for Graduate Education, Department of Pathology and Laboratory Medicine, University of Pennsylvania, Perelman School of Medicine. He is also known as the lab hero for working at the cutting edge and driving forward the future of the field of cytopathology and clinical pathology, and therefore he has been included in the pathologist power list several times and amongst United States top doctors and best doctors in America. It's very difficult to put forward to you all his salient features. But again, let me be very precise. He has more than 200 publications, has contributed book chapters and well-cited review articles. He's on the editorial board of many international high-impact journals, and the list of his affiliation to various professional organizations and life membership is very impressive and at the same time very long to be enumerated at this point of time. He seems to be equally renowned in various endocrinologic societies and associations, and especially Thyroid Association and their societies. One of his forte is thyroid cytology, to which he has contributed tremendously, and the best thing being that he is a core cytologist for the designing of the TBS RTC. We are all waiting to listen to you, Dr. Zubair. Thank you so much for accepting our invitation to give a talk at this platform of Golden Jubilee Lecture Series. Welcome to you, and the e-platform is all yours. Thank you.
Thank you so much, Dr. Kamal. This was an amazing lineup that I don't even remember all these things, but the best honor is that folks like you and who have really committed to the field consider me as one of your peers, and that is the best honor anybody can bestow upon me. So thank you again for inviting me. So without further ado, I am going to share my screen, and Sandeep, do you see my screen?
Yes, it's visible.
Okay, good, excellent. So what I'm going to talk to you about is something that some of you may find kind of basic, but I think the basic things are very important because it kind of grounds us. It kind of brings us to ground zero again and tells us, hold on, you are forgetting some very important basic things. Because when we do things every single day, we try to like kind of lose the sight of, and I think this is the best part about cytopathology, because we are so tied to our basic concepts that it really makes us someone that can really look forward and teach the concepts, learn the concepts, and keep on reminding ourselves that we are the basic cytopathologist. And whatever comes is, I think, is the layering and on the top of it. So, but I'm going to start my talk with this person's life, who is not with us anymore. But, you know, I really learned my cytology from a lot of people, and still I keep on learning. And I think that is the way I will live, because I keep on learning. But the love of cytology started when I met Dr. Gupta. And Dr. Gupta, when I joined him as my mentor during my fellowship and as a director of fellowship. And I stayed at Penn. One of the main reasons I stayed in Penn was two people who really mentored me in thyroid. One was Dr. Gupta for cytology, and one was Dr. Lavolsi. And Dr. Gupta, I considered him as my teacher, as my mentor, and my friend. And as some of you may know him. So I'm dedicating this talk and all of my teachings that I do to Dr. Gupta, and I will always remain thankful for what he has done for me. So we're going to start with, this is where my discussion is going to center upon, and we're going to talk about thyroid nodules, how they're selected for FNA, and this will be, some of these will be opinions, and some of them may appear a little bit controversial to you because it applies what I'm going to talk about mostly is from the US point of view. And then we're going to talk about a little bit about surgical pathology, because I also do surgical pathology. That's what half of that, what I do is endocrine pathology also. So I think it's very important because most of us do consider surgical pathology as our gold standard. And we're going to also touch upon some of the basic stuff, which I think is very important. As you know, thyroid nodules are common. They are very common in adults, and even in US and other areas which are iodine sufficient, you can see thyroid nodules, and we're talking about palpable thyroid nodules in up to 7% of population. But if we put a neck ultrasound, if you do neck ultrasound, which is a very common screening modalities, including CT and PET scan, you're going to find one or more thyroid nodules of different sizes in up to 60% of the population, even in iodine sufficient areas. So this is a very common disease. The good news is that 90% or plus are benign, and then less than 10% are malignant. They are more common in women, but when they occur in men, they tend to be more on the aggressive side. So just let's go through the thyroid nodule stats a little bit. As I said, the majority of them are benign, but I also want to remind you that some of them may be associated with different syndromes, or there may be a little bit of a developmental abnormalities that can lead to a thyroid mass or nodules. The most common tumor of thyroid is papillary carcinoma, and it is the part of the well-differentiated carcinomas because they make thyroglobulin and they secrete thyroglobulin, and that's why they can be actually post-surgery, they can be screened if there is a tumor recurrence. The other thing of that, and I'm sure that you come across this, I think the paradigms or the clinical management paradigms that apply to adult thyroid nodules are a little bit different when you think of the pediatric thyroid nodules. And then I'm a little bit of a thyroid nodule geek. So whenever I go to the museums, I always take pictures of when they are showing. And here you can see there's a picture of Christ there. And as you can see, there's a little kid or angel, and you can see that he has the goiter. So I always take these pictures because to me, it's important to see that these thyroid nodules have plagued us since centuries. So when you think about pediatric thyroid nodules, they're less common than adults, but the rate of malignancy is much higher, which can be up to 25%. And it is the second most common malignancy in the girls between the age of 15 and 19. So the other thing to consider about the pediatric thyroid nodules is that the risk factors for carcinomas are associated with autoimmune thyroiditis as well as with some genetic syndromes. One of the key factors that we're going to come up a little bit later in this talk is that hyperfunctioning or the thyroid nodules, which are toxic or toxic adenomas in adults, tend to be more on the benign side. So those are toxic adenomas or a part of a toxic nodular goiter. But in kids, the hyperfunctioning nodules can be malignant. So the rate of malignancy in a hyperfunctioning thyroid nodule in a pediatric population is much higher as compared to adults. In adults, is almost negligible. So those are some things I think it's important to really kind of keep in mind. So now let's talk about thyroid nodule evaluation and selection for FNA. I think this is something, something that every cytopathologist should know, whether you are biopsying the nodules or you're just reading the thyroid FNAs. And even if you're doing surgical pathology, I think this is very important information. So when you clinically, a patient with a thyroid nodule is evaluated, all this stuff that I have listed at a history is very important. The family history of thyroid cancer does not just apply to medullary thyroid carcinoma, but is now extending even to papillary thyroid carcinomas. Even 2 or 3 family members with a history of papillary microcarcinoma, thyroid removed for some other reasons, or goiter, really puts the family at risk. So those families, our kids have to be screened in these cases. So we're finding more and more of these cases, and this list keeps on growing. Now, the way the patients are selected, I think the cheapest test, and even if you are doing a thyroid nodule biopsy, is to check patients' TSH. The most patients who are going to be selected for thyroid nodule biopsies are either euthyroid, and as you know, the TSH range is very high. It's from 0.3 to 5, which is the international units, which is the normal range. So either the patient is euthyroid or hypothyroid, that means TSH is high. Those are the patients that will be selected for thyroid nodules biopsies if the thyroid nodules are found in them. But if the patient is hyperthyroid, the one of these tests has to be done is the radionuclide scan to see which part of the nodule, or if the nodule is hyperfunctioning. And hyperfunctioning nodules should not be biopsied because they will give rise to a very cellular specimen. So this is a radionuclide scan, and it shows you this very photopenic area, and this is the true nodule. Now, the problem is even the malignant nodules tend to be photopenic or hypofunctioning. I don't use the term hot and cold because to me that's like a beverage term, hot beverage, cold beverage. So I use the term photopenic or hyperfunctioning or hypofunctioning. And as you can see, this is a beautiful example where the surrounding thyroid is all eufunctioning or kind of functioning because they are making thyroid hormone, except this nodule, which is photopenic. So in a gland which is hyperfunctioning, and if the patient's TSH is low, the radionuclide scan really tells you which area to go and biopsy, if the nodule is functioning or non-functioning. Now, this is not going to apply to pediatric population because hyperfunctioning nodules can be malignant. As you know, the thyroid biopsy is performed by using 25 to 27 gauge needle. I love 27 gauge needle because it gives you less bloody specimen. Plus, when I'm looking at search path, the thyroid nodule, the morphology or histomorphology is not distorted by FNA. So I love 27 gauge. And most of the, I'm getting actually kind of, what do you say that I'm going to kind of spoil? I like ultrasound guided biopsies because I know it targets that really suspicious areas within a nodule. So let's go for a little bit talk about ultrasound. As we know, that some of you who do ultrasound, there are good landmarks that thyroid ultrasound tells you. It really tells you the lobe, the structure of the lobe, and how it relates to the surrounding structures. And this is something that I always keep in my mind, even if I'm on site and looking at the thyroid nodules being biopsied. So the main structure that really I always look for is the tracheal rings, and it kind of tells me about the isthmus, the lobes, and how the vessels like the jugular and carotid are related to it. So naturally, you can utilize this to really target the specific areas. This is the buzzwords that are used. So these are the nodules which have hypoechoic, have calcifications, or what is now called as echogenic foci. That means microcalcifications, margins, and vascularity. This is also very important. So if you look at those, the ones which are starred on these slides really kind of make the nodule go up and more suspicious. And those are the nodules that will be targeted. Based upon ultrasound features, there are guidelines. I don't know which guidelines are followed in India, but there are guidelines for American Thyroid Association. And then there are guidelines from other different societies, basically risk stratification schemes to really target the nodules which are less versus highly suspicious. So the risk assessment actually begins with clinical history as well as with radiologic features. This is one of the newer article that came out, and I was honored to be part of this team. And actually, these are the diagrams I made myself for this paper, and this paper is publicly available. It's from American Association of Clinical Endocrinologists. As you can see, this cartoons really kind of matches with, so this is really a basic benign nodule, which is spongiform in appearance. That means it has equal distribution of hyper and hypoechoic areas. And these are areas, as you can see, these bright spots is actually colloid. As compared to this nodule, which has microcalcifications or echogenic foci, and you can see it even has extension into the surrounding muscle. So this will be highly suspicious or a malignant nodule. So based upon these images, you can really target and really have classification of these nodules which are going to be malignant or which are going to be benign. And I think this is a very important information for the cytopathologist. Cytomorphology always wins, but I think these really help us to refine our diagnosis. Now let's go to cytology. Let's talk about classification scheme. You all know Bethesda, the first edition, And I was very integral part of it. Actually, I was part of the honor to be the part of the first chapter authorship. And we really worked, it took 1 year of my life, but I think it was all worth it. And as you can see, there's diagnostic categories, there is risk of malignancy, and then there is management scenarios based upon that risk of malignancy. There is a middle group, which we all call the gray zone, and it has the atypical and neoplasm because cytology can only go so far. What I'm very proud of this classification is that it really reflects the spectrum of the lesions that you are going to see in your clinical practice. Now let's think about it. I think the most important thing is, we can make any classification scheme, but those have to be impactful. And I think the timing of the first edition of Bethesda classification scheme was very, very important because it came at the time when there was a lot of tussle going on the surgical pathology diagnosis of the follicular variant of papillary thyroid carcinoma, especially follicular variant. Clinicians were talking about that we are over-treating that low-risk cancers in the thyroid. The radiology societies were coming up with these risk assessment guidelines, and we were learning more about the pathogenesis and the molecular profile of the thyroid tumor. So I think this was the right time for this classification scheme. And this is one of my favorite studies, which is from 2016. And as you can see, this is the management scenarios that the clinicians developed based upon what happens to a specific diagnosis, which is made based upon the Bethesda classification scheme. I always call it a tiered classification scheme because there are similar classification schemes from other societies. So you can see how this is where the proof is that this classification scheme or your diagnosis really matters on how this patient is managed. Because we can make a diagnosis, go home, close our microscopes, and if we don't know what happens to the patient, to me, it still stays in the vacuum. So I think this is a great proof for that. Now, one thing, when we talk about a specific diagnostic category in Bethesda classification scheme, we always think of risk of malignancy because that is part of it. And us being a pathologist or cytopathologist, we kind of get tied to it. The problem is that this was based upon the literature review. So I was responsible for collecting all this literature, doing meta-analysis, and coming up with these numbers. But when you apply this to the daily practice of cytopathology, there is going to be a change. And the change is going to be that you're going to see this very differently. Now, the problem is that when you get tied to risk of malignancy for various diagnostic categories, and you say, oh, you know what, it has to be 4 to 14% or 1 to 3%, you are actually looking at, or you're getting your view kind of skewed because the risk of malignancy is going to be only based upon those patients that went under surgery. Now, what about other patients in that specific diagnostic category that did not go under surgical excision? So it is a super saturated number that you're looking, which in reality may not work out as such. So that should be a guide, but should not be a gospel that you always have to follow. So I think this is very important. The other thing we always forget that risk of malignancy relates to patients demographics, age group, size of tumor, clinical presentation, or selection for FNA. If you have a clinician who picking up all little nodules, which are even benign for FNA, your benign cohort is going to be really, really big, which is good, but it's going to affect your risk of malignancies for other lesions. Or if you are not proficient in looking at thyroid FNAs, you may call a lot of things atypical. You are not aware this was a hyperfunctioning nodule. You are not aware that the patient was syndromic. He had Dicer-1 syndrome or some other syndrome. You have this very cellular specimen. You called it a neoplasm or suspicious for carcinoma. Your number of atypical cases is going to go up. So this is all effect. So I think this is a guide, but not the gospel that we should follow. So now let's look at the classification scheme, which came at this one. and then what happens at the second edition. So this is the second edition, but let's look at the changes that happened before the second edition. One of the major changes was NIFT-P, what we called as formerly as encapsulated, non-invasive follicular variant of papillary thyroid carcinoma is now, we took away the word carcinoma because these tumors behave in a benign fashion. And a lot of patients were getting total thyroidectomies and even radioactive iodine for this, which was not important. So this whole paradigm changed, and this is our gold standard. So if you look at this, there was a lot of studies published, and what it showed you that the risk of malignancy dropped for AUS plus diagnosis or suspicious for follicular neoplasm diagnosis, and especially for suspicious for malignancy, because those are the cases, as we know, some of the cases of follicular variant really do not have perfect papillary cancer nuclei. And those are the ones that is going to give us trouble on cytology. And we are going to call some of these, or actually I will say majority of these, up to 60% of these, atypical neoplasm or suspicious for malignancy. So if you say NIFT-P is not carcinoma, your risk of malignancy is going to drop. And this is where the problems happen for us. And that's what is reflected in the second edition. So the second edition, I think I'm again proud that it took the NIFT-P equation into consideration and changed the risk of malignancy, but it also provided these optional notes for cytopathologists to use when you're using a specific diagnostic category. Why did we do this? Because we cytopathologists, at least in US, are always afraid of getting sued because we did, pap smears, and you know that some people do get sued. Whenever you make a diagnosis, there's always somebody's may say, oh, I'm not sure. So that happens. And I still remember a quote from Dr. Rosai when I was at Memorial, and he said, if you are going to be afraid of making mistakes, you will never be able to diagnose anything as you want. So I think this was a very important lesson I learned. So naturally, these notes kind of help you, the clinician, know that one of the follow-up of these diagnoses may be NIFT-P or even a follicular adenoma. So that is the nature of this beast. And I think these notes kind of help us with that. Now, in pediatric thyroid nodules, when you apply the Bethesda classification scheme, I will tell you that the treatment for suspicious for malignancy and the malignant will be the same, because the risk of malignancy is almost 100%, even for suspicious for malignancy. So just to keep in mind if you're coming across a pediatric thyroid nodule. The atypical category is not just for Bethesda, it is even for RC Path, which was actually, I have to give credit to Dr. Poehler from London. And this was actually the first thyroid tiered classification scheme was from RC Path, then was Bethesda, and you can see the other classification scheme. And I do apologize if I missed a classification scheme from India or from Pakistan or from other countries. But I think these are the main classification schemes that are being used. What I do want to point out that if you really look at this, and let me see if I can do this, just bear with me. I think this is very important that if you look at these categories, you can see how these different classification schemes handle it. Some actually break it down more into other categories. So, just be aware of it because, all the cytology is becoming very universal. And this is what these classification schemes are supposed to do. So again, let's get tied to the risk of malignancy. But I think it's very important to start thinking about in the international terms of this. And when you look at these studies, so this is actually one of my favorite studies. I am actually a stickler for meta-analysis because to me, this is really tells you how the things are being done. So if you look at the AUS plus category and you look at between the Asian series, so this is the Asian series, and you can see the frequency and between the US and look at the differences and the risk of malignancies in this. So demographics, patient population really affect that risk of malignancy. And this is a very important findings to know. Now, this is another study. This actually came from India, and this is another one of my favorite studies. They looked at AUS plus cases, and as you can see the difference between the risk of malignancy between India, Asia, and the Western studies. what I really love this study about is that they looked at the overall risk of malignancy also. And that is my favorite, because you take all comers into the equation, whether they have surgery or not. And you can see how it really balances out when you take the entire population. Some of you may not agree with me, but statistical people will tell you that this is actually the best way of looking at things. And, so the risk of malignancy to me actually kind of lies between the absolute risk of malignancy, which is based upon patients going under surgical resection, versus all with those diagnoses. So true risk of malignancy is somewhere here. So which is good. That's why I like the ranges for these risk of malignancies. Now, the thyroid cancer also being molecularly profiled. And one of the best studies is a TCGA study. And then there are other studies which layered upon it. As we know, you can actually base thyroid cancer based upon molecular drivers. And there is a BRAF is more common in papillary type tumors that make papillae, which includes classic papillary, tall cell, and other. Follicular pattern tumors were more RAS-like tumors, and they had also PAX-7 PPRA gamma. And then there was poorly differentiated anaplastic and medullary carcinomas. And this list keep on growing. And there's a whole subset of tumors that we are now realizing, which is actually a mixture and really aggressive growth patterns, is the NTRK-associated tumors, which are also common in the pediatric age group. So this kind of opens up my mind when I think about nodules, diagnosed cancers, or even if I'm looking on the surgical pathology slides. So let's go to the general considerations. And I'm going to start talking about this very quickly, because I think this is something I remind myself of. What about when you correlate ultrasound with the surgical pathology follow-up? One of the things that haunts us all is microfollicles. I really not put too much stress upon it. I think what is important to me is monotonous cell population, because neoplasms are clonal, and the clonal proliferations is more important than structures. But that is one of the things that we all struggle with. Other thing is oncocytes and lymphocytes. Chronic lymphocytic thyroiditis is very common. This history is very important, because this is the disease of the iodine sufficient areas. And as you know, the oncocytes can be very, very atypical. So be aware of this. This is where the more of the AUS diagnoses are going to go. Preparations. Thin prep preparations, if some of you use, the morphology changes, and even changes for papillary thyroid carcinomas. So this is something in the everyday practice that we really face. Now let's put everything together. Radiology or ultrasound is a spongiform nodule. You're going to see features of hyperplastic nodule. I'm not going to go through them because I know you're all proficient in that. Flat sheets, tissue culture effect, and even papillary formations. Chronic lymphocytic thyroiditis, a diffuse process, is going to give you oncocytes and these lymphocytic tangles, lymphocytes in the background and percolating among the follicular cells, looks similar to what you see on SearchPath. A papillary carcinoma is going to give you microcalcification and high-risk pattern on ultrasound. Cytology features, we all know elongated nuclei, chromatin changes, and intranuclear grooves. And this is really a classic diagnosis of a classic papillary thyroid carcinoma. A follicular neoplasm case is going to be a very rounded nodule, which will be hypoechoic. That means the echogenicity is less or more distributed than the surrounding thyroid. You're going to see this halo effect. Well, this looks like an adenoma on SearchPath, but what you're going to see, this monotonous population, cohesive groups of cells, and less colloid in the background. Oncocytic nodules can be actually hyperechoic or brighter on ultrasound, and you are going to get a population of Hürthle cells with these transgressing beautiful vessels. Remember, nuclear atypia is common in oncocytes and should not be taken as to differentiate between adenomas and carcinomas. And I know there are some studies available on it. So let's think about questions and controversies that I feel. One of my commonest controversy that I will see is nodules which measure 1 centimeter or less. Think of lesions. If you're thinking of cancers, most common are papillary carcinomas. Follicular carcinomas measuring 1 centimeter, very, very rare. Rarely, Hürthle cell carcinomas can be 1 centimeter. think of other possibilities, medullary microcarcinoma, and also intrathyroidal parathyroid lesions, because this is very important. So before you make a diagnosis of follicular neoplasm or AUS plus, because you saw some microfollicles, think how many of these are going to be follicular carcinomas. This is a parathyroid FNA, just looks like a follicular neoplasm. You have a lot of cells here, which are forming these cohesive clusters, as you can see here. Even you are seeing the vessels, so there is papillary formations here, and you can be mistaken if you just go by architecture. The best way is to do a rinse. So whenever there's a nodule is small, sitting on one of the opposite lobes, poles of the thyroid, or even intrathyroidal, too vascular or too round on ultrasound, I always say, can this be parathyroid? Ask about PTH levels, calcium level of the patient, or even if it's still suspicious, take a rinse and submit for PTH analysis, or get a cell block and do immunostains for PTH and get up. And I will tell you how many times I have come across this. Things to be remembering about marked nuclear atypia. Personally, I think the only nuclear atypia that matters when you're thinking about follicular derived lesions, that means originating from follicular cells, is the papillary carcinoma nuclei. You can see random nuclear atypia in thyroid lesions, and most of these are benign. Long-standing goiter, patient on synthroid, Graves' disease, chronic lymphocytic thyroiditis. So in those cases, that clinical history that I spend a lot of time on is very, very important. This is a case of a 45-year-old genetic female, thyroid FNA. Somebody outside call it cannot exclude poorly differentiated carcinoma. Look at the nuclei, really large, but it's still very cohesive. And this is a very random effect. This is not like all nuclei look like this. And this is very important finding. This was actually, when I asked for more history, patient is Graves' disease, long-term methimazole therapy, and the entire thyroid had uptake, hyperfunctioning. There was no nodule, it was just enlarged, and somebody put a needle in it. So I think this is a very important finding to really not to overcall these patients. Another case, this is actually my case. And I showed this to Dr. Gupta when he was alive, and Dr. Gupta started laughing at me because he said, you know, are you sure? And I said, look at all these lymphocytes in the background. One of the things, the patients with chronic lymphocytic thyroiditis, when they are being screened for other cancers, these nodules arising in chronic lymphocytic thyroiditis, oncocytic lesions, are PET positive because they take up FDG uptake is very high, and they light up like Christmas tree. And then naturally you have to exclude, this is not metastatic disease. Look at the nuclei, they are so atypical looking. But when this thyroid came out, because a surgeon still didn't believe my diagnosis, I called it chronic lymphocytic thyroiditis with atypia, and I said, this is reactive atypia. It's not because I was right and wrong, but I put that in that context. And look at this. This is all chronic lymphocytic thyroiditis, same nuclei. So this was a very marked atypia and chronic lymphocytic thyroiditis. Other case, you can see nuclear chromatin clearing, which can really mimic papillary thyroid carcinoma in the background of chronic lymphocytic thyroiditis. Look at all these lymphocytes, such an important finding. And when this thyroid came out, it was nothing but diffuse chronic lymphocytic thyroiditis, and you can see how clear these nuclei are. Papillary formations, not only papillary carcinoma, you can see them in goiter, you can see them in Graves' disease, and even papillary hyperplastic nodules, which are for pediatric patients. So be aware of these. And as you can see, the lesional cell cytology, because we are cytopathologists, is more important than just the architecture. This is a case of a benign papillary formation that was called as suspicious for papillary carcinoma. But look at the nuclei. There is still very round, really do not have nuclear features. Look at this structure, papillary formation, but look at the subfollicles here. So that is a very important finding of papillary hyperplastic nodules. They can be oncocytic, and in young kids, they can be hyperfunctioning. So that additional information is really helpful. Sampling heterogeneity, who is biopsying the nodules. So let's take this follicular pattern lesion. has macrofollicles, microfollicles. But look at the nuclei. So this is actually a papillary thyroid carcinoma, and now it's a NIFT-P. If the needle only stays in this area, it's going to look benign. But if the needle goes in this area, you'll be able to see those lesional cells. So the thyroid nodules, especially which are isoechoic or even hyper or hypoechoic, the needle should target multiple areas to get the complete picture. Another case of a benign nodule, lot of colloid papillary formations in this. When the biopsy is done, if the needle stays in this area, you're going to get what is going to look like a benign aspirate. If the needle only stays in this area, you're going to get something and you're going to say, can this be AUS or FLUS? So I always remind myself, and if I'm on site, I will tell the radiologist, please move the needle throughout this nodule because I want to see the representative sample, not just the targeted one sample. History of prior FNA is very important, and I sometimes get beaten up for this. Prior FNA can cause a havoc in thyroid if a smaller gauge needle is used. And you can see here, these are very atypical cells. And this was actually a young girl in which the diagnosis of anaplastic carcinoma was made upon this. And when the case came to me as a consult, and it's not like because I was an expert, I looked at it and I was like 16-year-old with a history, with the diagnosis of anaplastic carcinoma. So I got more history. She just had an FNA 3 days ago and they repeated the FNA because it was non-diagnostic. This is the nodule on surgical excision. Nothing but a bag of granulation tissue in this. There's no follicular cells. And if you really look at these cells, what you're getting atypical, they're not follicular cells, they're actually cells from the granulation tissue. So these are actually endothelial cells. So all this really matters to really target, for us to really think about what are the reasons for AUS plus to really decrease that category, because this is, I think, the category we really have to get more handle upon. Think of pediatric thyroid lesions is very important. One of the commonest papillary carcinomas that we don't see in adults that you're going to see in kids is diffuse sclerosing variant. This by radiology or ultrasound is a malignant disease because you're seeing this multiple echogenic foci throughout the thyroid. You need an expert ultrasonographer for this. Somebody else who's just is not used to doing neck ultrasound may read this as chronic lymphocytic thyroiditis, or may overread chronic lymphocytic thyroiditis as papillary carcinoma. So it goes both ways. They have multiple psammoma bodies. So this is definitely tumor, but look at the background of chronic lymphocytic thyroiditis. I don't know what happens, why there's chronic lymphocytic thyroiditis, if the tumor is arising in it, or this is coming like after due to the tumor, but multiple psammoma bodies, squamoid looking foci, and you see this on cytology also. Think of other functioning lesions that we see in kids. And remember, this we saw in adults also. Papillary hyperplastic nodule will give you a very cellular specimen. Think of functionality. But if you look at these nuclei, even if they look like pseudopapillary groups, look at the nuclei. They really are not that of papillary carcinoma. This hormonogenetic goiter, abnormal thyroid function tests in some of these patients will give you a lot of random nuclear atypia and thyroid nodules. So in a kid, I always ask the question, how are the thyroid function tests? What is the family history? The other thing that I'm seeing now is the patients with the P10 hematoma syndrome. They actually have multiple thyroid nodules. The other thing to consider, sometimes these kids are not seeing the expert and they have totally missed the other features of P10 in that patient. They just saw this neck and they said, oh, there's thyroid nodules. These nodules very cellular. And if you're a fan of microfollicles, this is a follicular neoplasm or beyond. So, but naturally no nuclear features of PTC. So think of these other lesions when you're doing in the kids. I think that knowledge is very important. Now let's do a very quick exercise about NIFT-P. And I'm sure you guys are making this diagnosis on SearchPath in India also. I think the struggle is with how you handle these cases. This is one of the cases, and I'm going to show you 1.9 centimeter nodule. Look at some of these nuclei, which really are cleared out. and they actually have these beautiful thick nuclear membranes, so kind of suspicious looking. Think of what you're going to call them. Follow-up was NIFT-P on this. Very circumscribed nodule, non-invasive, and you can see here really a follicular pattern consisting of macro and micro follicles. So that lesion will give you a lot of colloid on FNA. And if you look at the nuclear features, those are nuclear features of papillary thyroid carcinoma. This case, 2.5 centimeter nodule, suspicious features, no ultrasound available on that. This looks papillary formation. Look at the nucleus. So what are you going to call this? Follow-up was classic PTC. Next case, forming follicles. Let's go a little high on this, and let's think about how that is going to look. What are you going to call this case? Look at the nuclei. Look at the beautiful intranuclear grooves that are here, and then look at the chromatin and the thickened nuclear membranes. The follow-up on this case was invasive follicular variant. Why did I show you this case? Because of this NIFT-P diagnosis, some of us are really nervous. Should you be downgrading the things that you call specifically before as suspicious for PTC or even PTC because you do not have those perfect nuclei? Remember, the perfect nuclei are also going to be in NIFT-P, at least in some cases. So this is the struggle that I always get asked upon, and even me and my colleagues go through it. Because, so the problem is now, should you only call cases papillary carcinoma when you have these beautiful papillary formations and you have everything that looks like papillary carcinoma, which is going to be, so, which is naturally, has inclusions, definitely some of my bodies, or should you, this case, you should not call papillary carcinoma because it has these groupings and then you're not sure and you're going to call it suspicious. So this is going to lead to downgrading your diagnosis because you're going to be afraid what the follow-up was. But remember, the good news is the most endocrinologists are looking at the pre-test probability of this being cancer. And cytology is just one part of that equation. It's not everything. We think it's everything, but I think it's important in nowadays how these cases are being managed. And other thing is that the NIFT-P, nobody says it's a benign disease. It behaves in a benign fashion, but it's still a neoplasm. We still need more studies to see how these tumors are going to behave. Plus, we have to say how this is being diagnosed on SearchPath. Are we following the strict criteria for this? So this is my version of the Bethesda classification scheme. You look at the colloid, you look at the follicular cells, and then you really, based upon your criteria that you use, this is going to range from benign to malignant, and then definitely there's going to be these middle categories of which is what we call as indeterminate, and some people even use this as indeterminate, which I think is a separate because suspicious for malignancy has a higher malignancy rate. Now let's move to this a little bit quickly. Oncogenic drivers, we talked about it. This is a very good information. And even this is now being applied to surgical pathology. I'm one of the editors actually on the 5th edition of WHO endocrine tumor classification that is coming out within a year or so. And we are writing this up. And this was a big tussle that should we be now really defining these tumors based upon their architecture or based upon the molecular drivers. So this is going to become more and more important. And naturally, the countries like, I'm not saying just India, but other countries, sometimes these tests are very expensive and not available. So the cytopathology is still the driver of this thing. But let's just quickly talk about the molecular test, if you're using it and what I sometimes use. They're all different. They use different methodologies, and they give you a probability based upon the negative and positive predictive value. What are the chances of cancer it will be? And actually, they can pick up other lesions like medullary or even parathyroid lesions or METs. They are very expensive tests, but if you look at the sensitivity and the specificity of these tests, the three most common tests that we use is basically not that far apart. Naturally, some have a lower than the others, but they're they're pretty good tests. So I don't have a stock in them. I wish I did, but they're basically performing at the same level. So they do help. So look at this lesion, hypoechoic nodule, very suspicious. And this was the FNA, which was called as suspicious for PTC. And let me just go higher on this so you guys can believe me a little bit. Because just saying that it may not be. And as you can see this beautiful nuclei here with the internuclear grooves and stuff. So this was called suspicious for PTC. It was reported on molecular as having NRAS mutations, and the patient underwent only lobectomy because RAS is associated with the low-risk tumors most commonly, and this was actually a NIFT-P. Another case, this case was mine, that I call as follicular neoplasm because a monotonous cell population forming very cohesive clusters. This case had RAS mutations plus TERT promoter mutations. Majority of the lesion looked like a NIFT-P, but then there was one area with necrosis and trabecular formation, and this was actually a poorly differentiated carcinoma. So this TERT promoter mutation did cause the surgeon to do a total thyroidectomy and also lymph node dissection. And this patient actually had positive lymph nodes. So I think this is where it really helps you. Another case, you can see a very well-rounded structure, kind of a little hyperechoic, looked like an oncocytic neoplasm. This was negative for molecular analysis because the Hürthle cell tumors or oncocytic tumors do not have the same mutations as you see in the other follicular derived tumors. And this was actually a follicular adenoma. So this is where the ultrasound was really helpful. And this patient just went under lobectomy because the ultrasound was not high risk. This is the institutional data, which we use ThyroSeq, and I'm not saying ThyroSeq is better than the other test, and that is a disclaimer here. But as you can see, I like the word, which is the benign call rate, which is to me is very important. And this AUS plus, you can see what you can imagine, the benign call rate is much higher on molecular. So 82% of the nodule in this study that we call AUS plus were benign, as compared to the ones which we call follicular neoplasm, 54% were benign. So there's a difference between these two categories. And I think it's very important because some people still say that Bethesda 3 and 4 should be combined in one category. I think the follow-up is does not support that. The other thing to note that when you have multiple when you have RAS mutations or they were associated with copy number alteration, so additional molecular alteration really increases the chances of malignancy. So that is something also important to remember, and that has been shown also in the surgical pathology data. So my summary of this talk is, I think it's very important, even if you don't remember the entire talk. I think what is really important is when you're looking at these specimens is to think of clinical features and anything that is used to assess these nodules. I know some of you may not be able to get that information, but make friends with the radiologist, make friends with your clinicians. I know I can only talk about it because I'm in an academic center, but I think it applies to all of them because at the end of each slide is a patient. It's not just about us at that point. How you're interpreting thyroid FNA, I'm not going to teach you how to interpret it. You have your own criteria. You're all seasoned cytopathologists or students of cytopathology, as I say. I think that's a better term to use. Whatever you make the diagnosis, I think whatever scheme you use, Korean, Australian, Japanese, RCPath, Bethesda, tiered scheme is much better because it really reflects the practice and what you see on SearchPath. And I think the morphologic features, everything counts on a cytology slide because it's a very small specimen of a larger lesion. How it is biopsied, again, is very important. And actually, you have to pay attention to the background, to the cells, and everything in context of the clinical and the ultrasound features. And I think this is some of us, as I know, I'm sure most of you also do surgical pathology. And I think what the data is gathered on the ultrasound in light of the cytology, and if you plus the molecular test or no, I think it all reflects to what we see on SearchPath. And then in SearchPath, you can see they can be also stratified according to the stratification schemes from other clinical societies into low risk, intermediate risk, and high risk. And thank God, most of the common lesions that you are going to see on cytology that we see are going to be these low risk tumors. So we really have to be really diligent about getting this other information, which is going to prove to be helpful. So I'm going to end my talk with this. I think the last year, as you know, and you guys have seen the burnt of this, it has become, to me, it has become more and more important. I really don't worry about the race, the religion, where we are from. We all, I think it's so become so universal, especially when it comes to medical education and our profession. It's universal. I think this is, to me, is the religion to follow, is the humanity. And I am becoming more and more aware of these beautiful things that I am surrounded by. And sometimes we all live in our head. Those are the points, and we really don't take an account of our family, our friends, and even the smaller things like plants that we are surrounded by. And these are the pictures I have taken. And some of these pictures these Buddhist pictures were given to me by one of my friends. Taking account of what is important. And that to me is something that makes me somebody who's like, hold on to this and what I do every day. So thank you so much for inviting me. I'm going to stop sharing again. And thank you everybody for taking time to attend this talk. So thank you.
Thank you so much, Dr. Zubair. That was totally fascinating. And I must say that the audience have sent in a lot of appreciative comments about the beauty of your pictures. And may I add that your cytology pictures are as beautiful, but your other pictures are equally beautiful. So there are lots of questions and comments which has been generated from your talk. Dr. Radhika wants to know whether NIFP rates vary across geographic regions and whether the frequency of NIFP can be the lead to variation in the risk of malignancy estimation.
Yes. So remember that before NIFP, the encapsulated follicular variant of papillary thyroid carcinoma diagnosis was very variable. And that has been shown in the studies, right? So the diagnosis ranged from being a hyperplastic nodule to adenoma to carcinoma. And this is what we are seeing in NIFP also, but the variation is very small. The other thing I think one has to be very careful about what is being called as NIFP. When I make this diagnosis, I make sure that the entire tumor is submitted. Remember, you have to have no invasion. That means you have to submit the entire capsule and the tumor. No papillae, because when we did the first paper, we said the papillae were allowed up to 3%. Now we said no papillae. Solid growth. So you have to exclude that possibility. And they come in different sizes. That means the entire specimen has to be submitted based upon the current guidelines we are using for making this diagnosis. So if you look at those studies which have used these guidelines, which are not many because most of these studies are retrospective, definitely it varies. And so still, that variation will exist, but the NIFP diagnosis coming from those centers which are following this, they have seen a drop. They have seen the risk of malignancy go up and down, and they have actually seen their atypical go up initially, but now I think it's leveling off. And we have started working on the 3rd edition of Bethesda system. I just got a mandate from Dr. Ali and to really start writing the 1st chapter. And I'm collecting data, and I think there was an initial period when everything went up, and now I see it kind of leveling down. So I think, yes, but I think it will come to a plateau, and then these atypical rates will go down. Variation will stay, but you have to remember variation is not a bad idea if you really look at the population. So where this variation is also, I think, patient demographics. So I hope I answered the question.
Yes, you did indeed. And there is a follow-up question from Dr. Tanupreet on, is there a molecular signature for NIFP, and is NIFP the only reason for change in the risk of malignancy percentages?
So I'm going to answer it in the other way around. So no, NIFP was not the only reason. Remember, the second edition of the Bethesda is based upon the prospective studies after the first edition. NIFP was one of the drivers, but also the molecular testing and what type of surgery is being done is becoming more important. Before, when you made a diagnosis of even follicular neoplasm in a 4-centimeter nodule, the patient got total thyroidectomy. But now most surgeons are doing lobectomy, and which I think is a big win for the patient for this really almost biologically indolent disease. Now, so I think that something has to be taken into account. Most NIFPs have NRAS mutations. And if you look at the allelic frequency, which is the amount of the mutations, is much less. They have the same type of mutations that you see what is called into minimally invasive follicular carcinomas, or even up to 20% of follicular adenomas. So if you really think about in a global term of the RAS-driven tumors, and most commonly NRAS, it's going to be follicular adenoma, and some of these, even when we call them adenomatoid nodules, NIFP, follicular variant of papillary carcinomas, and follicular carcinomas. Now, when the tumor invades, so if you have a molecular signature on an FNA of NRAS, but there's other copy number alterations or other mutations associated with it, then the risk of malignancy goes up. So I think those tumors have shown to be more angioinvasive or invasive.
Yeah, thanks. Dr. Bharat Rekhi wants to know about AI, or artificial intelligence, in thyroid cytology. What is the role?
Well, there is papers out there, and some people completely believe in it. As long as the input in the AI, and I mean, I think it's the AI, it's all depending upon the input, like what we put in, right? As long as somebody who's teaching that and making it validated knows in the pre-test probabilities, post-test probabilities, knows what other factors are important in reading this. I personally don't have any experience, but what has been published or people who are working on it looks important and looks better. But I think all those, I will believe in it, and hopefully I will be retired by then, so nobody's going to ask me to do this. But I mean, I think there's definitely something that is going to be. Remember, when the molecular test came out, everybody said, oh, the molecular test is going to be the one that is going to really drive how we do cytology. I think it does, but at the same time, if I look at the big picture, I'm still calling, greater than 60% of my specimens as benign, and they don't see the molecular test. So you have removed that from the equation completely, and it's going to, so I don't know, there's a lot of factors. I cannot completely answer that question, but I will say to you, this has to be seen. Definitely, I'm never going to say no, because I'm always learning, but I think this has to be seen, how it really going to play out. And I think it applies to all cytology specimens, so I think if you really take putting everything in account, like clinical stratification, ultrasound, cytology, without even taking molecular from the equation, I think we do a fabulous job. Because remember, before World War II, any thyroid nodule, their patients were getting completion thyroidectomy. I think we should be very proud of ourselves that we have saved so many necks, especially from the surgeons who are not proficient in removing these, thyroids, because neck is a big organ, and causing damage to everything else. So I still think cytology wins. I'm sorry, I sound too old-fashioned, but that's my approach.
No, I absolutely agree. So the AI is only as good as its teacher.
Yeah, it's biased. I mean, it's like the personal biases.
So we have a couple of interesting questions. Dr. Vani Ravikumar asked, do you do core needle biopsies of the thyroid? And Dr. Bharat again is asking, what's your perspective on frozen sections?
Oh my God, two of my favorite subjects, and I get actually beaten up, and I change my talk where I'm giving my talk. But I'm among friends, so that's fine. So the core needle biopsies, if you look at the data has mostly come from Asian countries like Korea, China even. I think a majority of it is coming from Korea and the other places. I think, to be honest, there are two factors with core needle biopsies, and the studies that are done in US and the other countries have shown this. The core biopsy, if you look at the atypical rate, especially the cases that are being called suspicious for follicular neoplasm, or follicular neoplasm goes up in core needle biopsies. Because remember, the core needle biopsy is a targeted, whereas the FNA or even the exfoliative cytology is covering a greater surface area if you're doing really a good biopsy. So for me, I have seen more atypical diagnosis being made on the core biopsy, or say follicular pattern lesion or follicular neoplasm or follicular lesion. I have found core needle biopsies in cases where there's a repeated non-diagnostic FNAs and the nodule is calcified or fibrotic. I have seen in those. I have attended 2 core biopsies in patients with just general thyroid nodule, and patient had a large, huge hematoma in the neck because the thyroid is very vascular. So you have to be proficient. I'm not dissing core biopsies, but I think with a 27 gauge needle, you get so much information. And if you really compare it, there's not much difference. So yes, core needle biopsy may help, but so what are you going to do with a core biopsy? Let's say HBME and CK19 immunostate. We have seen there's a lot of pitfalls with those stains also. The other thing I've seen core biopsies, and I'll tell you, I have been asked to be part of a lawsuit and I said no, because somebody called on a core biopsy, papillary thyroid carcinoma. The core biopsy, the way it was fixed, every single nucleus, and this applies to frozen section also, every single cell has a hole in it in the nucleus. Multiple intranuclear inclusions, and that was actually a fixation artifact. So I will say core needle biopsy is helpful when there's a metastatic disease and you want to exclude thyroid versus MET. It's helpful in calcified and amyloid-rich medullary carcinomas, and it's also good for non-diagnostic fibrotic, but those are really selected cases. Frozen sections. I'm glad I trained with Dr. Lawolsey, and she hates frozen sections. I think frozen sections. So what does the frozen section provides you? It kind of basically a guide. Do more surgery, stop, you have the lesion, right? Papillary carcinoma diagnosis, cytology is going to be really good in 90+ cases. So really, you don't need it. Follicular pattern lesions, follicular carcinoma, very focal invasion. If that tumor is invading all over the place, you don't need frozen section. The gross examination is going to tell you in situ that this is cancer. So that you may miss even that. So most of the frozen sections I have said, they're being called as follicular lesion, encapsulated follicular lesion. Plus, frozen section can really mimic a lot of nuclei of papillary carcinoma. So you have to be very careful with I really don't like frozen section. I only like frozen section when the diagnosis is there another tumor? Is there something like a parathyroid or some other lesion invading? I will do a frozen section. But I have trained also the surgeons now, and I tell them, whenever somebody young comes from other hospital, they're always, they're into frozen sections, and they go like, well, tell me if it's papillary cancer. And I said, no, I'm not going to be able to tell you that. I'd rather do a touch prep on the lesion and tell them, but I don't think, if you really look at the basics and what frozen section offers, I don't think, if they're going to do a lobectomy for a low risk lesion, why do you want a frozen section? I'd rather it be nicely fixed for my histology sections than for frozen. I'm sorry, I'm giving these negative answers, but I can only come from an experience and what I have seen.
Well, I must say, I also agree completely with what you say. Frozen sections and core needles really don't help. Another interesting question from Dr. Radhika. Do you take material for molecular analysis all the time for every time you do an ultrasound guided FNA?
No, we don't. So what we do is we go, so see, because we are a training institution, so we go on site for every single FNAs or the training goes. And if they see a case which they think is going to be either one of these atypical categories. If I think it's going to be a hyperplastic nodule, I do not collect any of the molecular specimens. If the clinician said, oh, I'm worried about ultrasound, and I go like, this looks like a benign nodule, I will not collect it. And we have been right. There's 6 or 7 of us, and we've been right most of the time. When I think it's going to be one of these follicular neoplasm type lesions or suspicious, I will collect for molecular. So yes, I think it will be an overkill to collect for every specimen. I know some centers do that, and they end up actually tossing it. But remember, somebody told me, actually, this is very interesting. I'm not going to take too much time, but I will tell you. One of the pathologists said, when there is a molecular vial sitting in that fridge, I go like, why should I be making a benign diagnosis? Shouldn't I call it atypical and let molecular answer it? So I think that is such a human nature. So no, so we do not, to make it a short answer, no, we do not collect it for anything. All of them, we only collect. Yes, if a surgeon is doing an FNA on their own and we are not on site, and I said, look at the ultrasound. If you think it is more chances of being some kind of a neoplastic process, which is still, in a percentage wise, you can collect a vial.
Yeah.
I hope I answered the question.
Yes, you did indeed. And that's a very helpful answer for a lot of us because we do a lot of thyroid cytology. The other question is from me. Do you do a cell block in every FNA? We have tried FNA cell blocks. They don't work so well. The success rate of getting material is low.
So beautifully said. So you actually answered it. I find cell block to have much more kind of problematic, because in the cell block, what really floats is that one microfollicle or something that curls up and looks like a papillary formation. So I rather have the material sitting in a cup, and I rather have another cytology prep made, like a cytospin or a thin prep, rather than cell block. Yes, so metastatic lesions or some lesions where I'm afraid that's a parathyroid or a medullary carcinoma, I will tell them to do a cell block, but that rate has gone down. I have found that collecting a rinse for PTH or even calcitonin is much helpful than me trying to figure out the immunos on the cell block. So those are the only instances. So I prefer cytology preps better than cell blocks when it comes to cell blocks.
So do you prepare direct smears at all, or you do everything on?
Yeah, so I was trained by Dr. Gupta. He said your cytology diagnosis is as good as your smear. So that stuck in my head. I think you can see the beautiful cytology on a Diff-Quick or Romanovsky stain smears. PAP, so we do Romanovsky stent smears, PAP stain smears, and then we rinse it in the Cytolite because we use thin prep now, and we do so those are the 3 preparations. And I think it keeps your mind open. It's good for teaching if you're teaching somebody, and it's something that you can go back to and really look at the background. And I think they're good for correlation. Oh, I'm not saying thin prep is bad, but having only thin prep, you lose a lot of background features and stuff. So I still like the mixture of all 3.
Yeah, that's absolutely fascinating. I think we will start doing that, in fact. Dr. Malati asks, what is who does the FNA? Is it the cytopathologist, the endocrinologist, or the surgeon?
So I will say everybody. Most of our FNAs are done by radiologist or endocrinologist. We also have an ultrasound machine that we have bought, and we'll go in-house and then do FNAs ourselves. I'm actually proud when we do FNAs because I don't know, I'm being facetious here. So I think that's good. And I think this is a one field our cytopathologists should get involved and really should do it because we know what is going to look like on the slide and stuff. So the surgeons also do FNAs because, everybody is and has an office ultrasound, but most of our FNAs are done. I love FNAs when they're done by an endocrinologist because when I go there, I have the clinical history, I have the thyroid function test. They have used the classification scheme from ATA that I like. So it's to me that, but I do ask, so what I have done actually, what our director has done also, we have created a stamp that goes onto our requisition slip. And it has ultrasound features, lab test, everything listed on it. So they fill that in if we are not on site or somebody else is doing an FNA. But yes, majority by radiologists and endocrinologists, but we and also surgeons do FNA.
Those were extremely, I think, informative for all of us who are trying to improve our cytology all the time.
Yes.
I think we can have one last question, which is from Anupama Gupta. I'll paraphrase it. We get a lot of nuclear atypia in thyroid in benign conditions as well. And in India, we do have a lot of iodine deficiency disease in some parts, whereas in other parts, the iodine deficiency has gone away. But we have very high incidence of papillary carcinoma, especially in the northwest part of the world, of our country. So how do we deal with this?
So the thing is that when you have benign atypias, and I'm talking about the atypia and goiter, and remember, if you really look at the molecular level, the thyroid has patches, and that is called the patch theory. There are smaller clonal proliferations, and they can be hyperfunctioning by itself, and other surrounding it will be either suppressed because of that or eufunctioning. So the nuclear cytology is going to matter. Large, big, hyperchromatic nuclei, one or two sprinkled around, please don't worry about it. That is not going to be a tumor. Tumors do not look like this. I still wait for somebody to show me a case of poorly differentiated carcinoma, which only had 5 atypical nuclei. That doesn't happen. The nuclear atypia that really worries about is the nuclei of papillary carcinoma, grooves, elongated, chromatin clearing. If you only have few cells that are atypical looking, please don't call that atypical, because you will see grooves also in benign nodules. Look at your search path follow-up. Oncocytic cells are notorious for having nuclear grooves. So 1 or 2 cells with nuclear atypia, granted you have processed the entire specimen for cytology, don't worry about it. You're not going to miss anything. Multifocal atypia to me matters. To me, if there's a group of cells that look, and then as I'm driving through, I see more of those are the ones I really pay attention to. And depending upon my trigger for atypia or more, I then apply those diagnoses. So focal random atypia, which just looks like hyperchromatic large nuclei, be careful, because that to me is the atypia of a benign process. I hope I answered the question.
I think you answered that perfectly. May I request Dr. Radhika to please come on and give her closing comments?
Yeah, thank you so much, Dr. Zubair, and that was a fantastic presentation, and thank you for giving your time and answering so many questions. I think since we are just running short of time, and you have another meeting to attend, so I think we will have to end this session right now. And I really hope that you'll be able to visit us sometime in India someday. That is my wish and my dream. And thank you so much. And we are really grateful to you. And thanks to our chairperson, Dr. Kamal, and thanks to the moderator for moderating this session also excellently. All in all, we've had a wonderful Jewel 50 series here indeed. I mean, you've been the jewel, today's jewel, and thank you so much for it.
Thank you. Thank you so much. And congratulations. Thank you on your win. Thank you.
Yeah. I think we hope to make it to the International Congress of Cytology in 2022, the Indian contingent. Hopefully, we will be there physically, but well, we will definitely be there either physically or virtually. Thank you.
Thank you. Have a good day. Thank you.
Thank you. Good day.